to start his presentation. Aamir, if you give me 1 second, I'm going to pull up my screen so that we can look at your presentation through my screen. Please prompt me if you, Aamir, you need to turn on, you need to unmute yourself. Aamir, you prompt me when you want me to change the slide, okay?
Sure.
Okay, go ahead. Thank you for joining us.
Thank you, Petra, and welcome you all colleagues from across the globe, and welcome you from Pakistan. It's an unusual situation that right now I'm traveling from Lahore towards Islamabad. I'm not in a room setting, you can say. So to begin with, I'm not going to take much time. The National Action Plan, which has been prepared by Pakistan, and we are continuously in discussion within the country and from across the from Emro region as well, to seek support, as well as the Global Fund support is with us. We are taking them on board as well. The National Action Plan has been prepared, keeping in view the COVID as well as the TB in composition, and we have followed the April 4th World Global TB guidelines, and we are considering it according to that, what are the consideration for TB in this, and what actions we are going to, and the recommendation we have for is, for the people with TB likely to have an increased risk of COVID illness and death, while experiencing on COVID infection and TB remains limited, it is anticipated that people ill with both TB and COVID may have a poorer outcome, especially if the treatment is interrupted. As you are well aware, almost all the public health hospitals, they are not catering to the OPDs, only emergency services are ongoing. So we are keeping this in mind, that the large number of people who are already on treatment for drug sensitive as well as for drug resistance TB, that's a challenge for us, that how to keep the medicines, there should not be a interruption in the medicines. So we are providing them, those who were able to visit the facilities, we are giving them, instead of 1 month, we are providing them 2-month treatment. So, but still many people who are not able to visit the facilities, we are trying to reach through the courier service. The private providers are providing the medicine through their field staff, as well as in the biggest province like Punjab. We also have a field staff like Tehsil supervisor. They are visiting the home addresses of those individuals, which is an opportunity at the same time, but also a risk, because both can be exposed to COVID. Nobody knows that where the COVID lies. So at least we are anticipating that there is going to be an interruption and a poor treatment outcomes. That's one action, and that's what we are anticipating in Pakistan. We also have taken all the measures to ensure the continuity of services for people who need preventive and curative treatment. At the same time, if you can we move to the next slide, that is for the prevention. We are conducting the PHC assessment, primary healthcare assessment, which comprise the major number of basic management units which are catering to the TB services. And we are also exploring the ways how we can train the staff on IPC using the online services. So at the same time, we are assessing the IPC facility gaps, which could be administrative or environmental control, and the PPEs. PPEs short all across the globe, and that's the biggest challenge this COVID has put forward to all the countries, that PPEs are in short supply, and wherever they are, they're not readily available. So exposing the healthcare staff to the patients as well as the COVID, they are themselves getting victim. many doctors have been diagnosed with COVID. We are fortunate enough that we don't have a big number of casualties still in Pakistan, but it's a compounding effect that we are not yet sure how many COVID patients are in Pakistan, because we have a very limited testing facility. The testing facilities are, the more number of people are going to be tested, the more we will be knowing about it. For the diagnostic part, what we learned through our national reference lab, that previously in a week we were getting 200 samples, but currently it is less than 35 samples which are coming to us. So maybe in that way we are anticipating that the number of registered patients are drastically, they are going to be reduced in coming, if the and we are not sure how long it's going. If it stays longer, the larger would be the impact. If it stays shorter, but still apprehension would stay, and we are not sure whether the quarter, this April to June quarter, how much damage it's going to bring in forth, and which and the delayed diagnosis, there is a more the people will be more prone that maybe they are going to infect more people. So there is a risk also for the COVID as well for the TB patients. Treatment and care, as I've already shared, that we are wherever we can reach or wherever the people can approach us, we are trying to provide them 2 months treatment for drug sensitive and the drug resistant TB patients. There is a call center for mandatory TB notification. We are trying to explore how we can use that call center, because though it is not widely available to everybody, but still we are exploring how best we can utilize this. When we are also exploring the ways that maybe we can make small videos for patients, how to take especially for drug resistance patients, how to take care of themselves during this time, how to maintain the IPCs. We are also planning to place a contingency plan for drug resistance TB. The good thing which I would like to share, that we have drug resistance medicines available till June 2020. And there are some pipeline orders which we are hoping that the drugs are not going to be affected from the global drug facility, but the longer this blockage will remain internationally or nationally, it's going to affect the services. Also, we have drug-sensitive TB medicines till the end of 2020, which are available, and they are already been provided to the provinces as well as to the respective district to the grassroots level. For the diagnostic, till December 2020, LPA and expert cartridges are already, orders are placed. Midget supplies are available till December 2020. Can we move to the next slide, please? Yeah. Should all people being evaluated for TB also to be tested for COVID? That's we are exploring how best we can issue a diagnostic algorithm for testing of COVID and TB in consultation with provincial and TB control, because there are signs and symptoms which do mimic with each other, but due to apprehensions, many of the doctors and physicians, they are not yet aware how to differentiate between this time. Here, I would like to get the support from the colleagues abroad or whatever. If you have developed some kind of diagnostic algorithm, if you can share those, that would be very helpful for us to adopt to our situation. Also, in Pakistan, can TB and COVID be tested on the same type of specimen? Yeah, that's going to remain a challenge. That for COVID, we know that usually they're using the nasal swabs and these kind of things, but for sputum is required for the TB patients. That's need to be seen, and how molecular technology can be used for this. Though we know that experts cartridges which are being proposed and recommended by FDA as well for this COVID, but it's the challenge will remain how best we can use that, and definitely that Yasin is hearing me from that it's the biggest part is how we can procure it, and it's going to cost us a lot. Tests for COVID are done most commonly by nasopharyngeal and oropharyngeal. So that's what I've already shared. So let's see how best we can adopt to these situations. Is TB treatment different? That's the point 7. Is TB treatment different in people who have both TB and COVID? In most cases, TB treatment is not different in people with or without COVID. So experience on joint management of both COVID and TB remains to be seen. That's what we can anticipate at this point of time. For the private provider, the PPM situation, the contribution of the private providers, that's the next slide, please. Yeah. So the private providers are the pure general practitioner, as well as some private entities like engagement of the public hospitals, private medical colleges, prisons, detention center, military facilities, railway and public health insurance organization. So all these institutions, they are also responding towards the COVID emergency. All the OPDs in those hospitals are not being catered. So there are reports in some parts that prisoners are also screened for COVID, and there are some positive patients in one of the province. Few patients have been detected for COVID positive. So there is a big debate going on within the country between the High Courts and the Supreme Court that should some prisoners be released or they should be sent home. But the Supreme Court has a final say that the best possible screening and these things should be provided at the prison centers instead of sending them home. Let's see how it will remain in, but that's a total pure on part of the judiciary to decide. So we can't say what would be the future. But as I've already shared, that all the services are only catering towards the COVID emergency. The contribution of the private sector to TB case notification, definitely Pakistan is, in Pakistan, around 33% of the case notification is coming from the private partners. So almost 80%, 80 to 90% of the general practitioner or the major hospitals, they are almost working in a very limited capacity. So as well as the laboratories are not, all the laboratories are not functioning. So there is a expected that in this case notification is going to be very low in this currently this April to June quarter. And I wish we are hoping that this will not be prolonged. Indus is leading and Abrahm are leading in the COVID response in the province of Sindh as well as in Punjab. Also, they are responding in a big. Indus has a big hospital in Karachi. Karachi is the biggest city of Pakistan with the huge population. Abrahm is another very big institution with the private sector. So their intensive care is being almost overcrowded now. But they are leading and they are providing the best technical support to the provincial TB control program as well as the provincial government in the province of Sindh. Pharmacies are functional. That's a good thing in Pakistan that pharmacies are allowed. They are being functional. And PPAs, they are short everywhere. There is a big debate how to whom to provide to, but Global Fund has graciously supported Indus and Mercy Corps, and they have allowed them to use good amount of money to be used for purchasing the PPEs for the private providers. Mobile vans are also functional in some, for example, in one of the province in Quetta, they are using the mobile van with Gene Expert and CAD for X-ray installed for the screening and testing of the COVID as well as for the TB patients. So that's an opportunity in the community. Partners through field staff are providing medicines to the registered TB patients. So these are the things which are going on in Pakistan. For the time being, as I've already shared that I'm traveling at the same time, moving up country towards Islamabad. So maybe I'm not available for a longer period of time. If you have any questions, I would like to answer you maybe a day after.
Thank you so much, Aamir. That was fantastic. Thank you for the detailed outline, and thank you for updating us on the many activities in Pakistan, including the PPM situation. I do see that we have several questions. I would love to take you up on being able to answer the questions in detail online. I will take the questions afterwards and combine them with other panel members so that they can review, but I will prompt you, Aamir, to answer all the specific questions from participants online. Thank you so much. So you can be on the road again. Thank you for joining us.
My apologies.
No, be safe, be healthy. Thank you for joining us and for giving us your insights. And we look forward to seeing you online and interacting with you on the TBPPM network. Bye, Aamir.
Thank you. Thank you to all.
I would like to move on. We say goodbye to Aamir, and you can turn your, yes. Okay, bye. I'm moving on, and I'm really pleased that we have with us Jacqueline Ngozo from Kwazulu Natal. She's the director of the TB program, and she's going to talk to us about the situation in South Africa, and we're looking forward to hearing the updates from South Africa. Jackie, please go ahead.
Good afternoon, everyone. It's the afternoon here in Kwazulu Natal in South Africa. I'll start with, I don't have a prepared PowerPoint presentation, but I will just talk to the questions. What is the current situation of COVID-19 in our province, Kwazulu Natal in South Africa? What is the impact on the TB program at the moment? And looking at what is planned, I will highlight those with the anticipated challenges. So looking at our figures, we kind of try and keep tabs of the number of patients that have COVID-19 in the country and the province on daily basis. So as of today, we have in the country 1,686 patients that have tested COVID-19 positive. As a province, we have 257 patients, which is 15% of the country's recorded cases. So our situation is at the moment not so bad. We know that our first case that was diagnosed was on the 6th of March, which was diagnosed in KwaZulu Natal in Pietermaritzburg. It was somebody that came from Italy. But if you look at from that time up to now, we had some rapid increases around the 10th day from the 6th, but now we're just getting additional about 10 cases on daily basis. So we thinking we might have this under control. We're trying hard to check and trace, screen and test all the contacts of the patients that are testing positive. We are now planning to do a massive community screening and testing, but again, being guided where the hotspots are. We're currently trying to geomap, especially in our city, in eThekwini. That's where 80% of our cases are. In the other 10 districts, the cases are not that high. We're seeing that we have more males in the various age groups. So far, we haven't had recorded cases that have either TB or HIV amongst the cases that have COVID-19. But unfortunately, when we were collecting this information, although our surveillance is supposed to collect this information, but again, most of our cases were testing from the private sector, and this information was not really collected whether our patients that test positive for COVID have HIV or TB. So what we're doing now that we have hotspots for COVID, we try to map where our TB and HIV patients are, so that in those hotspots, we try and locate and protect our patients. But so far, so good. We haven't had any interruptions or disruptions of the services for both TB and HIV. We've had few patients that haven't come for their appointments as scheduled, but we have checked and chased those patients, and where possible, we have gone to deliver their treatment in their homes. And we're doing this in partnership with our funded partners who have been really very helpful to us. But again, we still anticipate the risk of COVID in people that are living with HIV. Unfortunately for us, we couldn't just plan for only TB control program because our co-infection rate is so high, above 60%. So when we were looking at TB, we looked at HIV as well, so that we really try and minimize the risk. But we also trying by all means that all the health facilities, including hospitals, are operational. But we have tried to minimize doing elective cases in the hospitals. So, and patients that are not so critical have been discharged home to make sure that the hospitals and the other health facilities are not that congested. Trying hard to protect the patients that are still going there and the healthcare workers. PPE is quite a challenge, but we haven't had any outages. We try to continuously order and borrow from one facility to another so that we make sure that our healthcare workers are actually protected. From public sector, we haven't had healthcare workers that have been reported to have COVID-19, but this has happened in the private hospitals, and those are actually in isolation, and some of those healthcare workers are actually admitted. We also anticipate that there might be delays, especially if our numbers for COVID-19 are increasing. There might be delays in diagnosis of HIV and TB patients, but in terms of laboratory, everything is in place. We have adequate cartridges for GeneXpect, and the courier services from facilities that do not have laboratories, like our primary healthcare clinic, that is continuing as usual. We also have tried to make sure we have adequate medication, although sourcing medication has been proven to be a struggle, but we haven't had any outages. Where possible, for both TB and HIV patients, we have been giving 2 months packs, but in some facilities that hasn't been, and with some medication that hasn't been quite possible. We have tried by all means through remote communication to send through all these plans to all our health facilities and managers so that everyone kind of knows what to do. I've highlighted on accelerated decanting of patients, especially using the normal pickup points, which we use for chronic medication. But even there, where possible, we just try and have repeat scripts so that we minimize patients coming to health facilities. Especially, we're trying to emphasize more on the out-of-facility community-based pickup points. Even in health facilities, we tried to put up, you know, some tents and mobile vehicles, so that at least the medication is collected outside the building of the hospital or the building of the clinic, so that we don't have overcrowded patients. And we know that in terms of infection prevention and the infrastructure, the health facilities are not the perfect place to be. So this is why we also set up these mobile temporal points outside the health facility. We have teams that are going out either to screen, test, and give education on COVID-19. We also make sure that we incorporate screening for TB as well, so that we can pick up TB patients quite early, and then they link them to the health facilities for testing, or sometimes they take the sputums on site where possible. Facilities have been also given guidance to actually look at HIV and TB patients as one of the vulnerable patients if they come to facilities, so that they are fast-tracked, so that they don't stay in the health facility for long, because that can be a risk for contracting COVID-19. I've highlighted on the outdoor clinic. We also have really emphasized the whole infection prevention for healthcare workers, and the use of PPE, social distancing, hand hygiene. That is the, you know, what we're preaching these days. We're lucky enough that private sector has been on board, especially the private laboratories, the private hospitals. Some of our patients have been admitted in private hospitals. So the guidance that we giving public sector, we also give the same guidance for our private hospitals, especially with the one of our private hospitals that had a number of COVID-19 patients diagnosed there. So we're doing everything that we can to make sure that we contain that situation. And we were also lucky that the funded organizations for both TB and HIV have been given a leeway by funders to actually assist the province, the districts, and health facility to kind of divert some of the funding to assist us with the COVID-19 and the protection for TB and HIV patients. I will stop there and maybe take questions if there are any.
Thank you, Jackie. Thank you. That was a great presentation. I get a lot of questions. I will just ask a few questions that were specifically for South Africa before moving on to Abraham from Ethiopia. There's one question about the testing, with congratulations about the mobile labs, and that is a really good initiative. They're asking, has this started already? Is the NHLS also testing for TB? And where is the testing for COVID done? And how long are the results? How long does it take to get the results? And a third question, for the geo-mapping and the mobile pickup, congratulations on that. Is this done only in KwaZulu Natal, or is it all over South Africa?
Okay. The testing for COVID-19, it started being centralized in Pretoria, but now it has been decentralized to one of our laboratories in Durban, Nkosi Albert Luthuli. So the turnaround time for the results is about 72 hours. That is patients that are coming forward to the public sector. But unfortunately, more than 70% of the patients test in public sector. And unfortunately, there are delays there. It could take up to 5 days, but there has been communication to try and mitigate and try and keep down that result turnaround time, especially in the private sector. We were hoping that we were, as a country, we're going to get a rapid test, but unfortunately, the processes of actually approving the rapid test hasn't gone through yet. So for now, we're still testing at a laboratory for COVID-19, specifically either in Pretoria or in for our province, specifically in Ngozo Albert Lutuli in somewhere in Durban. But for the TB testing, it happens in all healthcare facilities where there are laboratories. All our hospitals have a resident lab, and that is operational.
Thank you so much, Jackie. I have a lot more questions coming in. I will try and combine the questions for the end when we have a little bit of discussion. I might ask you afterwards to answer some of the specific questions online, but I'll try to address them after all the speakers. Thank you for your excellent presentation. I'm hoping you can stay online with us to answer some of the questions, but I'd like to ask Abraham now, could you talk to us from Ethiopia?
Thank you.
Abraham, Alemayehu is from Ethiopia. He's on the National TB Program, and he's also on the COVID Task Force. So he will be talking and presenting the situation in Ethiopia.
Okay, thank you. Welcome you all. And I'm going to present the situation where we are in. Is it visible? Okay, so before I go to details to share you the COVID situation, as a country, we have activated Public Health Emergency Operations Center and functioning to respond COVID-19. Regarding to the current situation, COVID-19 situation, in total, 2,271 total laboratory tests conducted, and among them, 264 last 24 hours. Regarding to the total COVID cases confirmed, 52. Among them, 8 are announced just today. 4 out of 52 cases, 4 cases were recovered. 46 cases are active, including 1 serious critical ill patient. 2 cases were reported. In general, the country is on curfew, but not full lockdown. Regarding to the impact of COVID-19 in Ethiopia, mainly it can be categorized into 2. One is social and economic crisis. The second one is healthcare delivery challenges. Under social and economic crisis, loss of lives and livelihood, travel restriction, food security, reduced economic activities, and among others. When we come to healthcare delivery challenges, disruption of basic health services, including TB service, hospital system may collapse, already started, healthcare workers may put themselves at risk, diversion of healthcare workers away from TB service, depleting and disrupting global supply chain are impact. For them, the actions to minimize COVID-19 negative impact. The first one is plan and take appropriate measure to reduce social and economic suffering, which is already underway. Under planning, put effort to reduce loss of lives and livelihood, provide protection for vulnerable population, including support for food security, financial barriers to access TB services, such as transportation, because the transportation restriction is there. Also execute strategies to limit economic collapse is also another strategy under economic and social measures. When we come to health-related measures, ensure continuity of core public health measures, such as find, diagnose, treat, contact tracing, care, and reporting, including for TB, important. For them, already the plan developed and sent to sub-national levels so that they to be implemented. Under health service, core public health service continuity, sustain essential health services, including TB, consider virtual option for DOT service provision, plan proactively and create means for supply delivery, minimize fund and HR diversion to COVID-19. Increase advocacy to visualize TB during epidemic. Other point is proactive, preemptive impact of COVID-19 on TB program and TB patients. Monitor emerging evidence on both diseases. Follow and execute global TB program directions. Work with national and sub-national stakeholders to ensure continuity of TB services. Work with national COVID response team, including advocacy for TB service continuity, for which already I have been dedicated to work with national COVID-19 response team. So I'm supporting and advocating the same. The other thing is develop guidance and monitor implementation to ensure TB service sustainability during COVID-19. So we also developed guidance and also shared to the relevant stakeholders, which is under implementation. Regarding to this guidance, the guidance mainly aimed to control damage on TB services. The purpose for this guidance is to give direction for healthcare workers and TB program coordinators on how to respond to COVID-19 epidemic with minimum acceptable impact on quality, accessibility, and sustainability of TB service. Under this guidance, different stakeholders are supposed to play role, for which we also allocated the role and responsibilities. That the stakeholder includes national and sub-national TB control program, health facility, community, CSO, and local organizations, patients themselves, developmental partner, and technical working group. If we look at the roles for national and subnational TB control programs, the first one is ensure availability of TB diagnostics and medicines, establish task force to respond uninterrupted supply during this epidemic, ensure sustainability of inpatient and outpatient TB services, functionality of TB laboratory and outpatient TB services, develop and disseminate message to public about diseases, develop and provide summary of TB clinical care protocol. Already, these activities already developed and sent to relevant stakeholders so that they can implement and identify more treatment supporters at community levels to enhance TB treatment adherence. Regarding to role at health facility level, patient triaging facility to consider separating those who have based on travel and contact history to COVID-19 affected settings, maximize TB infection control measures, orient and use more TB treatment supporters, provide one means adequate anti-TB medicines for patients, minimize TB diagnostic service interruption, and provide nutritional support for eligible TB and drug-resistant TB patients. When we look at the role for community, civic society organization, local community organizations, avoid stigmatization and discrimination of coughing patients, provide treatment, adherence monitoring support for patients, provide social and material support for needy TB patients, because the restriction may affect those patients who are in need of support, and engage and support community awareness raising activities. When we come to role of patient, mostly continue taking anti-TB medicine as per prescription, as emphasized. The role of developmental partners and technical working group, provide technical support to all levels, including National TB Control Program, and also enhance addressing funding gaps, are among others. When we come to initiatives in the private sectors, the guideline which was developed and shared, also inclusive for PPM sites, and the document also addressing them. Postal services containing specimen transportation. PPM sites will maintain TB service delivery, adhere to infection control measures, dispense one means adequate anti-TB medicines for each patient as per guideline, continue submitting regular report, and notify any COVID-19 suspects through toll-free lines or other available means. I would like to acknowledge Professor Mohan Pai, Canada researcher of epidemiology and global health at Guild University, Montreal, serves as director of global health. Petra Hakam and her team members for creating and facilitating global learning on PPM-TB. Lastly, but not least, audiences for their kind attention. Thank you. If you have any question or things need clarification, please welcome.
Thank you so much, Abraham. That was fantastic. Thank you for presenting this so clearly, and to everyone, all the presentations will be available after this webinar, so you can look at the details again. I have seen many questions coming up. There are several questions that are relevant for all panel members, so I will take this to the discussion time. There are a few clarifications for you, Abraham. One question was, can you please let us know what Ethiopia's case definitions are? Who are testing, and how are testing kits for COVID-19, how are they available? Also, can you give us examples of the virtual DOTS services in Ethiopia? And the third question, is Ethiopia planning to utilize COVID Cepheid cartridge, and if so, when do you plan to start? Could you give us a quick short answer on these three questions? All the other questions will come in the end.
Would I get the third question? Sorry.
The first question was Ethiopia's case definition and how are testing kits available? And can you give an example on the virtual DOTS service? And the third question, is Ethiopia using the Cepheid, the gene expert?
Okay, regarding to the third question, we haven't yet started using gene expert, but there is a proposals, also the direction, information note from World Health Organization. So we are considering how to optimally use for both. So we will discuss at public health emergency operation level and beyond. Then the decision will come later on. Regarding to the second question, currently we are using call-based, phone-based virtual service. So in our guidance, also we clearly indicated that one. And nationally, we are thinking other form of virtual DOT counseling, adherence supporting services. But for now, we have included call-based because the cell phone is prevalent, but we will consider others. For the case definition for COVID, we are using the same which is recommended by WHO. Yeah.
Thank you very much. Thank you for these clarifications. All the other questions, I'll take them to the end. Thank you, Abraham. I would like to see if I can ask Dr. Adebola Lawanson. She's the National TB Manager of Nigeria. Dr. Lawanson, are you, I'm going to unmute you. Thank you, Abraham, for getting out of the screen.
Yeah, thank you.
Dr. Lawanson, I can see that you are starting your video, but we can't see you yet.
Okay, all right, okay, fine.
Abraham, you need to, just 1 minute. Abraham, click at the top of the screen and stop share, please. Abraham? Abraham, you need to stop share. Okay, well, we will keep going. I'll try to get Abraham's attention. And Dr. Adebola, please, if you can start talking to us, that would be fantastic.
Thank you very much.
We cannot hear you, Dr. Adebola. Dr. Adebola, are you with us? I think we might have lost her connection.
Can you hear me?
Yes, now we can hear you and we can see you. Wonderful.
Right.
I'm
Okay,
so glad
fine.
to see your face.
All right, thank you. And the total number we have as at last night is 238 cases of COVID. 35 has been discharged. We have 5 deaths. So far in Nigeria, we have 36 states plus the Federal Capital Territory, which makes 37 states, so to say. And out of this, we have cases being reported for 14 states already. So when we're talking about what is the forecasted impact of COVID on our country, we know that for TB in particular, COVID has a lot of impact in terms of the treatment, diagnosis first, treatment and follow-up of services. And we all know that appropriate interventions must to be in place in order to minimize this impact. Some of the possible impacts that we had are the patient's movements are restricted because of, in order to respond appropriately to COVID in Nigeria, we have one of a multi-sectoral platform that is put together by the president. We call it Presidential Task Force, in which we have the Ministry of Health, and then we have the organization which we call the National Center for Disease Control, that is actually sort of in the center of all these the response. And we have also a number of other ministries. And the essence is to be able to respond appropriately to every aspect of the COVID. Particularly, we all know that apart from the health impact, we also have socio-economic impact and many other impacts. So in order to do this, we have the PTF, which is the Presidential Task Force in place. And in order to, not just to look after the patients alone, to ensure that we don't have community transmission, there have been total lockdown of movement, restriction of movement in a number of states. The president gave that order last week. We have the Lagos state where we have the highest number of cases. The Federal Capital Territory is also in the lockdown. There is one other state that is very close to Lagos state, is also the Ogun state is also under total lockdown. Some other places, states in Nigeria have some restricted movement all the same. But as we know, for the TB, we have patient movements have been restricted, preventing many of our patients to access treatment and support. And this may lead to treatment interruption and generate TB-resistant TB cases. We also see that diagnosis of TB-resistant TB may not have access to baseline investigation, and that may lead to delay in treatment. Sample movement is also being affected because of the restriction. Logistics distribution are also affected, and then this may lead to stock out. These are the possible impact that COVID may have on TB. Some facilities, particularly the tertiary institutions, where we are having OPD screening, routine OPD screening for TB case diagnosis, TB case finding, they are also is being affected. And we know many of the tertiary institutions are reducing their scope of their services, mainly to emergencies at the accident and emergencies. Community outreaches for active case notification is also affected. And then stigma associated with COVID is being also on the increase, particularly by the healthcare workers, and thereby affecting presumptive cases who come to seek care in the healthcare facilities. Then data collection is also being affected at this time. And then the use of gene expert diagnosis for COVID may also affect TB diagnosis if we do not plan very well. We envisage all of these problems. So one of the things we did before we had a total lockdown in country was, as a program and with our partners, we develop and disseminate a standard operating procedure to ensure that we have a continuous TB services during COVID-19 pandemic. This was shared with operational levels, that is our state TB programs, our local government TB supervisors, which we call the basic medical and basic management units for TB, and as well as the healthcare facilities. And the essence is to ensure that we do not shut down on the service provision. We developed this SOP, and the SOP in particular is supposed to ensure that we sustain services. People are supposed to be given, patients are given what we call additional drugs to take home. We actually instructed the facility level to make sure that they provide drugs for all our patients, additional drugs, that they should have at least 2 weeks or 1 month stock of drugs, and with their treatment supporters supporting them to make sure that this is done. We actually provided them, we asked this operational level to provide the patients with their treatment card, so that with that treatment card, they can fill in all the number of the days they are taking their medication. And also that card can also serve as pass if there is any need for them to come to the healthcare facility. But beyond that, we already at our end, we pre-position drugs, anti-TB medicines, both first line and second line drugs were moved to state to ensure that there are stock, about 7 months of stock of drugs, particularly for first line at all of these, or at our stores at the lower level, so that when patient needs these medicines, they can quickly have access to them. We also have 3 months buffer of cartridges moved to facility level to prevent stockouts. We move also appropriate PPE to the state, particularly now a lot of our TB providers are asking for N95 respirator and surgical masks are also being provided. So surgical masks are provided for patients to be used, but the N95 is for the healthcare workers. We provided pass for our logistic movement. That is, we call them third-party logistics movement to distribute program items when need be. One of the things that we also did was to ask each of the our state coordinators to form a COVID-19 TB response with their basic medical units, basic management units. The essence is for them to be able to ensure that we are able to, services are provided continuously and to identify challenges and provide solutions. And for us at the national level, what we did was to also set up a WhatsApp teleconference, a WhatsApp group first, and then a teleconference with our program managers on zone by zone basis. These are virtual meetings that we have to ensure that TB services are not interrupted and to ensure that we are able to identify challenges and provide solutions. Beyond this, we also been meeting with the WHO folks. These WHO folks that are positioned at the regional levels, that is at the zonal levels, as it were. We have some also WHO staff that are in some critical states, and these are like our proxy, helping us to monitor what is in the states. So we have a virtual meeting with them as well. So be able to gain what is happening at the states, ensure that challenges are quickly attended to, and we don't have any interruption to TB services. We also, again, set up virtual meetings with USAID, and the essence is to ensure that they support us to provide or to fill the additional gaps. We've also been meeting with the Global Fund on that virtually to ensure that all our challenges that we have are filled. Particularly now, we are looking at using the gene experts as a means of diagnosis for COVID. What the stakeholders, we had the stakeholders meeting as yesterday, and the essence of this is to be able to ensure that we set up testing sites. Apart from the PCR machines that are being used to diagnose these COVID patients, we want to set up the gene experts platform to be able to use in testing in all the states of the Federation. We have already done some of the things that we need to do. We've identified some of the gaps that we need to identify so that they can be filled. Particularly, we all know that we need biosafety for COVID. Even if you are going to use our TB reference laboratory that have biosafety outfit to be able to ensure that those are also used to test TB and to test for COVID-19. So one of the things we have said that instead of starting all over the country with use of GeneXpert, we want to face it. We are starting with the TB reference laboratory where we have the outfit, the biosafety outfit, and to use those ones to start in next couple of days to ensure and to after filling the various gaps, particularly having trained personnel and having adequate PPE to ensure that the health workers are well covered to be able to use that platform to test for COVID. And then also, as we scale up, we face the use of GeneXpert in all other states after having identified the gaps and fill the gaps and to ensure that they are safe for them to be able to provide some of these services. The essence of all of this is to make sure that we test as many people as possible for COVID and ensure that we do not also stop service providing services for TB. We also want to use, we have asked all our members and our officers, the state level as well as the local government, to leverage on the support that has been provided for COVID right now, leverage on the movement, sample movement, leverage on the resources that is coming from the states for increasing awareness, leverage on the resources also for movement of samples to be able to ensure that this is also done for TB. So all these are some of the things that we are leveraging on, so that we ensure that as we are increasing testing for COVID-19, we are also, it's not impacting negatively on TB, and then we are doing what we are expected to do. We have also asked the USAID for us to use what we call the WOW truck. The WOW truck is the mobile testing van for TB to be stationed in the high volume healthcare facilities, so that everyone that comes into the facility can also be tested for TB. And for us, we believe that at this time, we may have challenge with active case finding of TB in the facility, but in the community rather. But we are saying that our officers who are also part of the COVID-19 response in their various states should leverage on the contact tracing to also use that to see if we can use that to, again, increase TB case finding at the community level, since at this time we are really handicapped to do our routine active case finding. Talking about the private sector, we are, particularly in Lagos State, where we have total lockdown, the private sector has been mapped, and one of the things our partners that are supporting the private sector TB response in Lagos State has assisted Lagos State TB program to ensure that patients that needs to have their drug refilled go to the private sector to do that. That is very close to the private health facility that is very close to their houses. One of the things that the state is doing is to preposition drugs in these private facilities, so that those who need the drug, that is the patient that need the drug, when they run out of their medicines, can go there and get their drugs refilled, so that we don't have any interruption in drug service provision for the patient. Beyond this, we also have a reference laboratory in one of the private lab, and that is one of the private lab that we are prioritized now, because the reference lab and has all the facilities of biosafety, BSL2, BSL3 laboratory to be able to test for COVID. So they are also being brought on board to be able to support with the COVID testing. So invariably, these are some of the things that we have put in place to ensure that we have damage control plans for TB during this time. We have also emphasized to all our TB workers to ensure that they have PPE, particularly the N95, so as to ensure that they do not turn patient back and they do not stigmatize patients when patients come into the facility, so that they can provide the adequate TB treatment for all the patients. And like I said, also, we actually provided with hand sanitizer, with what it takes to be able to wash their hands to ensure that they are also safeguard. We also maintain the safety of the healthcare worker during this period. Like I said, we are regularly meeting virtually with our state control program managers at the state level on the regional basis, so that we can quickly attend to their challenges and ensure that we don't have interruption in service provision. So these are the things that we are actually doing at the national level for TB program in Nigeria.
Thank you, Dr. Lawanson. That was really so very helpful and so many excellent details. I have to say that I have 42 questions from participants. So people, thank you everyone very much for your engagement. And we have only 15 minutes left. I have 3 clarifications for Dr. Lawanson that I will bring up right now, and then we will move on to the discussion. One question, Dr. Lawanson, was, do you have enough masks and respiratory equipment? Do you have enough PPE in the country? The second question, for the Cepheus gene expert, what price are you paying for the cartridges? And the last question was, are you supplying private PPM sites also with PPE? And do they have the same standard operating procedures? Are they available for the PPM sites as well?
So thank you very much, Petra. For the first question, enough PPE? No. Because PPE, we don't have enough. And as of today, the Global Fund has given us approval to have an emergency procurement of additional PPE. And also, we've also reached out to other organizations. We've asked USAID also to provide for us additional PPEs so that we can distribute to all our service delivery TB service delivery outfits. The gene expert, for the gene expert, maybe I didn't quite get what you wanted me to talk about the gene expert. Could you please repeat that?
There was a question, it was, what is the price that you're paying for the cartridges?
For the gene, actually for now, we have not started using, I don't know, is it for the cartridges for TB or the cartridges for COVID? Which of them?
I'm assuming COVID, but
for COVID, we have not received that in the country. That's not arrived yet in the country. All we are doing now is to make sure that the gene expert machine is put in the right conditions, so that I mean to prepare the gene expert and prepare the healthcare workers who is going to man them, awaiting the arrival of the gene expert cartridges for COVID. Well, however, in country we have the cartridges for TB. We have that in country.
Perfect. And the last question was on the supply for the private.
Even all the PPM sites that are within our network, or the PPM sites that are within our network, are also provided with the PPEs, and we also ask the state control officers, who are the coordinators in their various states, to make sure that they circulate the SOPs to also the PPM sites.
Excellent, thank you so very much. dear participants and dear panelists, I have about 50 questions. We cannot answer all of them, unfortunately. However, I will take all the questions and we'll make sure that we get answers. I would like to, before we start answering some of your questions, I would like to give the floor to Jacob Creswell from the Stop TB Partnership to say a few words on the global partnerships activities specifically related to PPM.
Great, thank you, Petra, and thanks to all the other panelists and participants for being on the call. I just from a standpoint from where we sit at the partnership in Geneva and specifically the work that we coordinate around the TB Reach projects. I think not to repeat a lot of things that have been said from countries, but we do see huge restrictions, obviously, in a lot of the work that we're doing. The active case finding has all but stopped for the most part. Some of the panelists mentioned some activities, but most of the TB Reach projects have really stopped notifications. I saw a very alarming graph from India's Nikshay notification system where maybe 8,000 cases were being notified a day. That's dropped to less than half of that now once the lockdown came into effect. So it's certainly concerning from the TB response standpoint about how we are able to serve people who have TB better. You heard quite a bit about the generally the state where you have enough drugs, enough expert cartridges. But I do want to make a couple of points around the procurement system and questions related to both the COVID cartridges and expert procurement. We are looking at definite delays with expert procurement and cartridges. And this is mainly just a question of how many airplane flights are going out to countries and the ability to get expert tests into country. We're closely monitoring the situation with anti-TB drugs, many of which are being produced in India, and the lockdown is threatening to impact the ability or GDF to provide shipments. So that's something that is certainly that we're monitoring. For COVID cartridges, and a number of you may have seen the Gene Expert COVID announcement. The GDF is able to procure that as of last week. There is a standard price that is being offered of $20 US for that test. But I do want to say that GDF is accepting orders now. And it is also unclear from Cepheid how quickly and at what volumes the cartridge will be available for countries to order. So it would be great if countries are expecting to do this, to get those orders in very quickly so that you have some priority in that line, so to speak. I think some other things that were mentioned around Global Fund. Global Fund, we expect to make, but this is apart from any reprogramming efforts that different countries might be working on directly with Global Fund. But we expect Global Fund to make around $500 million available for disease programs to help address the COVID response. And I think our main message to TB programs and partners is to use these funds to support obviously the COVID response, but think about how to best support the TB program as well. So one very basic area and obvious is expert machines, gene expert machines. We have major issues with supply chains, as has been mentioned, and transport systems, and being able to decentralize testing will be an issue. So there is appetite and willingness at the Global Fund to be able to provide support for additional machines because of the need in testing. There are a number of other things that can be in. There's a webinar tomorrow that the partnership is putting on around the possibility of using artificial intelligence for COVID detection, something that the partnership has worked on quite a bit for chest x-rays and TB. But a number of the same companies are working on this AI work for the COVID response. So that's also something that might be built in to some of these requests. But really the chest x-ray machines in general, or x-ray machines in general, obviously PPE, but think about things that will help your TB programs. I think it was very heartening from to hear that laboratories and some of the private practitioners are being supportive of the TB programs. We hear a mixed bag from the partners that we work with, private practitioners not wanting to be involved with anyone with respiratory symptoms. But pharmacies and laboratories are still working, and we see very good collaboration in those areas. I do want to say, I know I don't have a lot of time, but I do want to make a plug. We have a TB Reach, and the Stop TB Partnership has an ongoing call for proposals for private sector TB response. So this is our grants that we provide to partners to improve case detection, and that we're accepting applications. You can find information on the website, but we do hope and expect that the COVID pandemic will subside and we'll be able to get back to some of the work that we're all primarily involved with. And the partnership wants to be able to support this as much as possible, and we're very happy to have USAID funding a large part of this call for proposals that is specifically around the private sector. So again, you can find out more information on our website. And finally, then just one last thing to note is that it was really great to hear, and I've seen a number of situation reports from Pakistan specifically, get them daily, but all of the speakers having up-to-date data on the COVID response. And it's something that I think as a TB program, we need to think more about, and maybe again, taking the opportunity for extra funding from Global Fund around building better data systems, information systems, so that we can get, right now we're going to be finding out what the impact from on the TB response over a year from now, when WHO reports their data in their report, which is just at this point in time unacceptable. And we've shown that countries can get very granular data very quickly from the COVID response, and I think it would be great to be able to move more in that direction, more countries in that direction. And the other thing related to this is the use of, for helping almost everyone has mentioned the supporting TB patients, people with TB on treatment. And a lot of the work that we have done in previous waves of funding has been around these treatment adherence, digital adherence technologies, which can be quite useful to be able to monitor people and support them as they take their TB treatment. There's a number of 99 dots, video, DOT, but it can be done very low tech through WhatsApp and these kind of things. So the partnership is really pushing to have as many tools out there as possible for TB programs. So I'll stop there, and I know there's lots of other questions for other people in that meet. So thanks a lot for the opportunity to talk.
Thank you, Jacob. That's really useful information with lots of good responses. I think we will be posting the different sources that you mentioned related to this webinar so that people can look back at the Stop TB Partnership resources and the different links that you mentioned, including the artificial intelligence webinar that's coming up tomorrow. So we are officially have 5 minutes left. What I would like to propose is that anyone who can stay on the line, I'm going to ask our panelists to have one closing remark, each of the 3 country representatives that are still with us. We've, from all the attendees, thank you so much for your attention. We've heard your concerns, we've heard your questions. I have collected all of the questions, and I will make sure that we will answer all of these individually, or they will be posted up on our forum afterwards, as will this full webinar and all the presentations. I think the 2 areas that where people have been asking the most questions are related to drug-resistant tuberculosis. Questions are for concern for patients. How do we do monthly checkups? How can we ensure that there is special management for the patients? How do facilities cope with the TB treatment when they have MDR-TB or XDR-TB patients? I think this is an area where I've seen many questions, and I would appreciate if the panelists can touch on that. The second question that has come up is related to protecting of the frontline TB healthcare workers. Obviously PPE equipment and materials, but beyond that, how do the programs look at motivating healthcare workers and their mental health? I think those are is an important area to look at as well. And the last question that I would like to ask the panelists is more generic. Like, as a TB manager, what are you most worried about right now, and what message would you like to give to everyone who is listening, and who and what would be the priority action steps that you would encourage everyone to take? So if I could look at Dr. Adebola, Dr. Abraham, and Dr. Jacqueline, and maybe ask who would like to start? Jacqueline, can I ask you to start?
Yes, I can start. I think I will talk about the motivation for the healthcare workers. I think it's very important to make sure that we support them, especially the supply of PPE. It's not really readily available now. But just to monitor, in the province, we kind of look at this on a daily basis, who has what, and try and redistribute as much as we can. Because from the healthcare workers that we have spoken to, they're really so worried and they're so scared for themselves and their families. So it's important that the first part of encouraging them to stay at work is to make sure that we provide as much PPE as we can. And again, sharing whatever information, especially because this is a new condition. So there's a lot of false information coming through, but we need to feed them with the correct and factual information all the time so that they can know how they can keep themselves safe, and again, how to assist their patients as well. For me, what I will be mostly worried about is active case finding for our TB cases. I'm not too worried about those that are already on treatment because they are kind of known to us. So if they don't show up, we know where they stay and we can find them. But it's the delays in diagnosis for those. This is why we have tried to incorporate, as the teams now are doing community screening and testing for COVID-19, just for us to do the symptom screening for TB so that we can start picking up our TB patients, especially in the segregate areas, informal settlements and so on. So I think for me, but I think what is also important is to learn lesson from COVID, because we have struggled to do proper contact management. So I think this is kind of teaching us a lot about, upscaling contact management for all our TB cases. So we're hopeful that we'll get as much resources as COVID and attention that COVID-19 is getting. Thank you.
Thank you, Jacqueline. Dr. Lawanson, are you still with us?
Yes, I'm with you.
Okay, perfect.
So,
wonderful.
Thank you very much. Yes, for me, Jacobs, I really don't think there is a problem because our healthcare facilities are opened. The only thing is that the social distancing should be practiced in those, even when patients are when they come in for their monthly checkup. Looking at the protection and motivation for healthcare workers, I know that it is a great trying time, and we don't want to expose them to COVID. So having enough PPE, as my colleague has said, is very important and crucial for these frontline healthcare workers, because when they are protected, they will be confident to provide the services for the patient. And as a TB manager, the greatest problem I have in Nigeria is TB case notification. So that is one that is giving me a lot of nightmare at this time, because I'm beginning to make a little bit of progress in finding my TB cases, and I don't want to go back. I don't want to go down in this TB and in the active case finding. But the situation I find myself now for COVID is running against active case search. So those are some other areas we want to see if we can have some innovations as to how best we can do it at this time. We know that the contact tracing can also be of great help for us at this time. As people are going in to do contact tracing, they can also, like my colleague said, they can do symptomatic screening for TB, and we can see how that is done. But as I have said earlier on, if we have patients coming to the healthcare facility, we can also do a lot of OPD screening. When they come in presenting as COVID patients, we can also do a lot of symptomatic screening so that we can actually, again, take samples for TB using some of these avenues. So these are some of the things that I feel we should, but more importantly, we want to have more information as to how best we can do active case finding during this era of COVID. Thank you.
Thank you so much. Thank you. And you've answered a few of the questions as well at the same time. Abrahm, are you still with us? Yes. Okay. Please go ahead.
All right. Thank you for the points. Regarding to the MDR and XDR or DR patients, in our guidance, we clearly indicated that all services, including monthly follow-up, to continue. The arrangement which proposed is the hospital, TIC, or the administrative levels, which is adjacent to that facility, to arrange transport for the patient so that they can pick and they can do follow-up through the arranged transport so that to save the patient in terms of COVID, as well as financially, and to escape that the restriction or curfew of transportation in the country. The other thing is regarding to the protecting frontline health workers. The one thing is we decided to space patient visits so that to minimize the exposure of potentially COVID patients. when we minimize the exposure, the staff, there is a probability to minimize a contact with a COVID patients. That is one. The other thing is provision of PPE, adequate PPE, and as per the recommendation, global and national recommendation. The other thing is minimizing the diversion of staff from TB program. That will help as well. And the other thing is, if possible, the shift and the local service as well also supports. Regarding to the worry about the one thing which we worry is the service continuity, because we don't know how long this disease or the epidemic will stay. If the epidemic, even if we planned nationally to continue the essential services, and even if we distributed the directive, but we don't know the extent of the impact of the disease. So that may affect the continuity of service. Because of the COVID, case finding activity may be affected. Not only the active case finding effort, but also the passive one also potentially affected. So this also other thing. The other thing is the usual way of provision of the treatment is DOT based. Now the things is changing. As I told, we have a limited access to use a video-based therapy and others because of the phone which our patient is currently possesses mostly not a smartphone. That may affect the DOT service. So that is also the worrying point. Other thing is the supply. We have a supply which may last for a number of months. If the condition lasts longer, it will be difficult because the global transportation system may be is being affected, and that will create deadlines, as well as the production of the TB supplies as well be impacted. So this also the worrying point. Other thing is the symptoms. If we look at the sinus, the symptoms similar TB, and they show cough, they show fever, they both show the shortness in breathing, and as we may reach another more similar symptom. Because of that, maybe the misdiagnosing will be there. So co-infection also worsen because both disease act on lung. It will affect the outcome of treatment. So those and other things are worrisome for us.
Thank you. Thank you, everyone. Thank you, all my panelists. I am very, very thankful for you taking this time out and giving us all these details on your activities, on the plans. It's been really good to hear the details from the different countries. And thank you to all the participants for the large amount of questions. We will be uploading all the information, all the website, all the presentations, the full webinar, including all the questions and with answers over the next few days. The webinar and the presentations will be available in several hours. We will make sure that everyone can download the presentation as well. And we thank you for your participation. We've launched a small little poll. If you would be willing to give us some answers, it will help us in prepping for a next webinar. Thank you to everyone. Have a good rest of the day or evening, and we look forward to seeing you again soon. Stay safe and stay healthy, and all the best for you and your families.
Thank you.
Thank you. Bye.
Thank
Bye.
you.